All right, welcome to everyone joining. We will start in about 5 minutes. Thank you for waking up early on a Sunday morning and joining us. And while we're waiting, if you want to just put in the chat where you're coming from, what state or what city. I always like to see who we have in the audience. Reno, welcome. SoCal. North Carolina, awesome. Fremont, my hometown. Texas, great. Welcome, everyone. Bay Area, St. Louis, SoCal, Georgia. Got folks from all over. Albuquerque, Wisconsin, Jersey, man. Buffalo, probably still nice and cold out there. Philadelphia. Idaho. Hey Thomas, how you doing? Reading, yeah. Minnesota. All right, and to those just joining, we're going to start in about 2 minutes. So feel free to grab a coffee or water and get ready for a nice educational session. NOLA, nice. It's one of my favorite cities in the US. Try to visit whenever I can. Habra, great. There's our Canadian. Los Angeles. I'm assuming that's an intentional misspelling. Welcome to those from Houston, Atlanta, and Massachusetts as well. San Antonio, another great place. UIW. Another Buffalo, nice. Hey, Fran. But where is your bed located? That's what we want to know. What state and what city? Hey, Vincent from Kansas City. Glad to have you. All right, more Jersey and Texas, great. Hey, Jess. Hey, Emmanuel. Got some local colleagues on here. Nice. And William as well. Nice. All right, we'll start in about 1 minute here. I'm just going to let a few more people file in. Hello to those from SoCal. All right, great. Well, we are going to go ahead and get started. Our speaker is very busy, and right after he does his lecture today, he actually has to run to a live lecture. So let's just go ahead and get started here. So thank you everyone for joining us. I know it's early on a Sunday morning for us West Coasters, and on the East Coast, we're just heading right into the afternoon. We got a great 1-hour CE session today. I'm going to give a few just introductory announcements, and then we're going to jump right into the lecture. So number one, if you haven't heard, we have teamed up with CSI to create a revenue cycle management basically program. And we are super excited about this. We just met with them for quite a while at Vision Expo. So we've custom designed this for ODsonFinance members. Best rates, and you can save a lot of money, save a lot of time, save a lot of headaches by managing both your billing and your coding and your revenue cycle management. And they also do credentialing as well. So scan that QR code if you're interested. You'll get the ODsonFinance rate. And once again, we have helped to curate this to make it the best possible. I use this personally in my practice. I know Julie is going to adapt it pretty soon as well. And it's a fantastic resource for anyone out there. And of course, OD Clinicals, if you haven't heard about this yet, absolutely free chairside tool that you can put on your exam room computer. It's a reference guide. It's got contact lenses. It's got ocular medications. It's got diseases. It's got everything under the sun. Just imagine an encyclopedia of everything, extremely searchable, very user-friendly, and very mobile-friendly as well. So you can put it on a tablet, on a phone, or on a computer. So scan that QR code or just go odclinicals.com and you'll be jumped right on the site. And we've got another CE event coming up, and this will be on April 24th. Super excited about this one. We've got Dr. Walt Whitley, Dr. Brianna Rue, and Dr. Habir Sian. You might remember him. He did a fantastic TED Talk just a while back that's become one of the biggest ones for optometry. And they're each going to present 1 hour of COPA-proof CE, and it's all going to be about the future of optometry. So we're going to be talking about e-commerce, how to sell online, and also kind of the role that technology is playing and where it's going for the future of our profession. So absolutely free, 3 hours of CE, April 24th, 9 a.m. So go ahead and scan that QR code. Make sure to sign up. We'd love to see all you there. And just a quick little teaser here. So stay tuned after this CE lecture. And we have an exciting profit-generating device that can help you take your diabetic and glaucoma management to the next level. It's reimbursed at $125 per exam. So stay tuned after the end of Dr. Ferrucci's talk to hear from Konan Medical about this. So just remember to mark that. And we also have a raffle at the end of the lecture. So stay tuned for that. So there's a lot of good ways to make money at the end of this lecture. So make sure to watch the whole thing and stay. All right. And I'm just going to go through a few disclaimers here as we jump into the CE portion of the lecture. And before we do jump into the CE portion, I want to take a quick poll, and we didn't set up a formal Zoom poll here, so just put it in the chat. How many of you manage diabetes or glaucoma patients or both? So just write diabetes, glaucoma, or both in the chat. That's going to really help out our speaker kind of curate his slides and his content for y'all. So I appreciate that. And while you're doing that, we're going to start the CE portion. So remember, answer the live poll question, which I just gave you. Remember to complete the survey afterwards. It's going to pop up once you close out the program. And you need to be present during the entirety of each hour to receive CE credit. Obviously, we're just doing 1 hour here. So Zoom does track that. CE certificates are going to go out about 3 weeks after this event. So just be aware of that. It does take a little time for us to submit your COPE ID number and then send out certificates. Any questions or any concerns, you can always email us, admin@odsonfinance.com. All right, and then I'm going to introduce our speaker today. So Dr. Stephen Ferrucci is currently Chief of Optometry at the Sepulveda VA Ambulatory Care Center and Nursing Home. He is also the residency director at his site and a professor at the Southern California College of Optometry, Marshall B. Ketchum University. Dr. Ferrucci has lectured and published extensively with a special interest in diabetes, diabetic eye disease, AMD, OCT, and fluorescein angiography. He's a fellow in both the American Academy of Optometry and the Optometric Retinal Society, as well as past president of the ORS. So Stephen, we are so glad to have you. I'm going to give the floor to you. Take it away.
Fantastic. Thank you so much. Let's just share my screen here and we'll be off to the races. So I was looking, people said that they manage, most people seem to manage both retina and glaucoma. I'm going to be talking more about retina today because that's sort of my passion. So what I'm going to be talking about is diagnosing, testing, and imaging for the posterior segment. And I'm really going to be highlighting two different modalities. I'm going to be talking about the Red Eval, and I'm going to be talking a little bit about OCT as well. And, I've done a similar program, and, there's other modalities as well. But in an hour, I thought this would be the two that I would focus on. And I think it really paints a nice clinical picture. So that's my hope. Really happy to be here lecturing to you guys. I always like to lecture to new groups. I was not familiar with your group, probably because I work at a VA and I don't know anything about marketing or finance or how to make money doing this or, anything. So it's really nice to talk to a new group. So you guys hear me good? Aaron? Cool. All right. So anyway, like Aaron said, Steve Ferrucci, I'm at one of the VAs out here in Los Angeles, California. We have 3 of them. I'm at one of them, and I've been out here for about 20 years or so. And, heavily medically based practice, lots of diabetes, lots of glaucoma. And my real passion, like I said, is really retina stuff. That's really what I enjoy, taking care of those patients, treating those patients, and that sort of thing. And it's sort of an exciting time to be doing that, because now we have some new equipment, we have some new treatments. So we have some new things, out there that we can talk about and that we can take better care of our patients. So like I said, I'm going to talk about a couple of those today. So disclosures, we always got to talk about our disclosures when we do a COPE review, a COPE approved talk. So these are the different companies that I work with in various capacities. I will be mentioning a couple of them today. So like I said, it's really an exciting time to be involved in patient care and especially retinal care, because there's a lot of new tools that allow better imaging, diagnosis, and management of patients with posterior pole disease, such as diabetes, macular degeneration, and that sort of thing, and glaucoma as well. And I'll probably hint on glaucoma, but that's not going to be the focus of my talk. But you can really use these to take better care of patients with retinal disease, to elevate your practice, I think, to make more intelligent and thoughtful referrals to retinal specialists and that sort of thing. And, I'm not a finance guy. After, Ian will be talking about how you can use this in your practice to actually make some money, because I work at a VA and I don't, that's not my focus. I'm more of a clinical guy. So today I'm going to talk about 2 things. I'm going to talk about the OCT and a little bit of OCTA, and then the full field ERG, which was the Red Eval. And part of the reason I chose these 2 things is I think they kind of go hand in hand, because an OCT is a structural test, and the full field ERG, the Red Eval, is a functional test. So just like for glaucoma, where we have structural tests, right, looking at the optic nerve, perhaps doing an OCT of the nerve fiber layer, a structural test, we also have a functional test being a visual field. And we use these 2 tests together in order to take better care of our patients with glaucoma, to decide who needs treatment, whose treatment needs to be adjusted, because perhaps they're not doing as well as we thought. And for a long time, we really didn't have any functional tests of the eye, at least not any that were readily available to us. But now with this Red Eval, we actually have a way to check the function of the eye. So I think by using our structure, the OCT, retinal photos, looking at the retina, and the functional tests, we can really take better care of our patients. So that's what I want to talk about today. So I thought I'd start with the Red Eval, because perhaps it's not as familiar to you as OCT is, and then we'll talk about OCT at the end. But the cool thing about the Red Eval, as you can see here, it's just a little handheld device that is able to do a full field ERG. So that's what we're going to be talking about today. And, back in the day when I was in school, I wasn't in school this long ago, but it was a while ago. ERG was like a huge thing. It was a big instrument. It certainly wasn't something you could do in clinical practice. It was more of a research type tool, but now we have it in a handheld device here. And essentially what the electroretinography does is it measures the electrical responses of various cells in the retina, including the photoreceptors, right, which are the rods and cones, the inner retinal cells, the bipolar and amacrine cells, and the ganglion cells in response to a stimulus. And we can use these to check the retinal health as well as the nerve health when we start to think about glaucoma, okay? Just as a brief, I don't really want to get, into, I always tell people, sometimes you don't need to know how these things work. I don't know how my cell phone works, but it works and it makes me happy. So sometimes you don't 100% need to know how these things work. You just have to know how to use them and get the information you need. But you can see here, the light goes into the eye, it travels through the retina, right? And then it hits the retina and then comes back. The A wave checks the photoreceptor integrity. The B wave checks the bipolar cell function. And these are the ones that we're going to use more for retinal disease, right? We'll see changes in the A wave, the implicit times, how long it takes for the message to get through the retina. And then the B wave is sort of the amplitude. And we'll talk about that in a second. And then the PHNR That's more used for glaucoma. So I might hit on that, but that's not going to be the focus while we're talking about. But like I said, you can see here the full field ERG, the Red Eval. It's handheld, completely portable, non-midriatic. You don't need to dilate the patient. You put these little sensor strips on the patient, and then you just hook these sensor strips up to the instrument, and it's really as simple as that. It takes a couple minutes. Simple user interface. It goes right into your existing computer. Normative database easily integrates into practice workflow because it's handheld, so you can use it, in wherever you want. You can have your tech go into the room and do it. You could do it in really any room you want. So it's really, really nice to do. Fixation not required, and works with media opacities as well. And this is sort of what it looks like here. You can see this. There's the docking station. Here's the machine itself, and then the docking station charges it and also will transmit the tests into the computer. And this is kind of what the patient sees. They kind of just look at this little red light. And if they can't see it, for, let's say they have macular degeneration or whatever, you could just tell them, just look straight ahead. And all the tech has to do is just keep their pupil in the center of this green square in order to get the measurements. And here's that sensor strip I was telling you about that goes under the eye. It always reminds me of like when you used to play baseball back in the day and you see the paint under their eyes, right? So it goes under there, and that's probably the biggest learning curve is just where do you put that little thing. But it's relatively simple, to be honest with you. But like I said, I liken and we're going to talk mainly about diabetic retinopathy and how I use it in diabetes. But I liken it to following patients with glaucoma, right? And like I mentioned, with glaucoma, we use structure and function. We use photos and OCTs. We look at the optic nerve head. We look at the nerve fiber layer. We look at the ganglion cells. And then we also use visual field, which is a functional test, to also see if there's any glaucomatous damage. And we know that very often the function and the structure don't go hand in hand, right? Patients can sometimes have functional loss. They can have visual field loss before structural loss, or vice versa. It's the same thing with diabetic retinopathy, that very often the functional loss precedes the actual evidence of diabetic retinopathy, right? So when you do ERG, sometimes you can start to see there's some damage in the retina before you actually start to see hemorrhages, cotton wool spots, neovascularization, and that sort of thing. So it really helps us follow these patients better, to sometimes see patients that are going in the wrong trajectory sooner, and also gives us a subjective measurement of their retinal health from their diabetes, which I think is important. And we'll talk about that a little bit. The nice thing is about the full field ERG is that when we think about visual acuity, all we're really doing is looking at the macula, right? And we know, and we've all seen it, these patients that have good vision, they could be 20/20 and have significant retinal disease that's outside of their fovea. So visual acuity really only looks at a tiny little part of the retinal function, right? And then a 24-2 patent ERG looks in a bigger area, but the full field ERG looks at the total retina. So it really looks at their total retinal health, and it gives us a really good idea of what's going on in their retina. So the interesting thing is that they've done studies on this, over time, and what they found through many publications starting way back in 1987 is that when you look at the ERG, as patients' diabetic retinopathy gets worse, right, they start to have changes in the ERG. And you can see here from no diabetic retinopathy on the one end to proliferative diabetic retinopathy on the other end, you can see how their ERG is changing. The amplitudes, right, are getting smaller. And they found that whoops, sorry about that. I didn't mean to hit that button. Son of a biscuit. What they found over time is as the disease gets worse, right, the amplitudes decrease. And it actually has a nice relationship between the ERG findings and the retinal findings. So the thing that, the Red Eval has a bunch of different tests you can do, right? It's got all kinds of tests. So however deep you want to get into the ERG, you can do it. But the tool that I like the best is called the DR assessment protocol. And the DR assessment protocol what it does is it just gives you one number, right? And this number, the DR assessment tool, is based on 4 components. It's based on the implicit time, the amplitude, the pupillary response, and the patient's age. So this goes into the, you put in the patient's age, and then you do this test, the DR assessment, and it comes out with a number, just simply one number, right? It uses an algorithm based on these 4 things to produce a number. And what they've found through multiple studies is that as that number increases, that indicates increasing disease severity and worsening retinal health. And what they found in these studies, if the DR score is greater than 23.4, that's sort of the magic number, 23.4. I was joking with Ian the other day. I wish they could have made it a more easier number to remember, right? Why not just 23? But it's not. It's 23.4. And what the study showed was that the DR score, if it's greater than 23.4, these patients have an 11 times increased risk of needing an ocular intervention within 3 years. And when I say ocular intervention, laser, anti-VEGF treatment, or something along those lines. So 23.4 is sort of the magic number. And if they have that number, this is a patient that's not doing well and is probably going to need treatment, 11 times more likely to need an ocular intervention within the next 3 years. So there's another study I thought was kind of interesting. And essentially what they did was they looked at the Red Eval scores, and they looked at the retinal photos, and they tried to just determine, which patients would go on to need treatment within the next 3 years. Excuse me. And if they used the Red Eval, they were able to predict this correctly about 35% of the time. If they used photos, they were able to predict who would need treatment about 22% of the time, just by looking at photos. So you can see that the Red Eval is better than actually looking at photos. But what I thought was really kind of interesting, and that's about 60% better. But what I thought was really interesting is if they used both, and both seemed to indicate that the patients needed treatment, about 70% of those needed an intervention. So by using the Red Eval along with your diagnostic exam, along with your dilated retinal exam, the two of them together are a very powerful tool to determine those patients that are going to need treatment. So I really like that, and I think it really is very, very helpful. So essentially, just like almost anything, right? It's color coded, and red is bad and green is good, right? And when you look at the report, obviously you want to look at the numbers, but basically that's how it works. And you want to look at implicit times and amplitudes. And implicit times are, how long it takes to get the signal in and out of the retina. And then the amplitude is the strength of the signal, right? How big the wave is. And the amplitude is the timing. And what happens a lot of times is when you have slow implicit times, that's indicative of cellular stress. And very often before you start to see any damage, you'll see the implicit times getting longer and longer and longer, indicating that this is a retina under stress that's eventually going to get damage. It'd be the same with glaucoma. You'd have slow implicit times. And then amplitudes, once you start to get decrease in amplitudes, generally speaking, that patient usually has active disease at that point. So you use these two things together in order to see if there's any damage. So this is an example, of a patient that has the DR assessment run on them, right? And you can see right up here, DR score 14.8. So remember I told you 24.3 is the magic number. This is 14.8, so we're good. So this is a patient that is doing fine, right? And you can see within normal limits. And then down here, when you look at the implicit times and the amplitudes, you can see that everything's green here. And then this is the pupillary response down here. And you can see again that everything's fine. So this is a patient that's doing fine. This is a normal test, nothing really to be too concerned with here. This is a patient that is not doing as well, right? This is a patient, you can see their DR scores 24.8, right? More than our magic number there. And right away, it lets you know, outside limits right away. It's very sort of, I don't want to say idiot proof, but it sort of is, right? And then when we look down here, we can see that the amplitudes are decreased in both eyes, shown here in the red. So this is a patient that's actually, having some damage. And then you would use this as long, and I don't have in this particular case what their retinal health looks like, but you'd use this along with the retinal health to determine what their best course of treatment is. If it's someone you need to see more frequently, or if it's someone that perhaps you need to refer out because you're worried that they might need some active treatment, right? So it can really help you in that way. And then this is a, like I said, I'm not really going to get into glaucoma. I don't use it out. I mean, I'll be honest with you. I said, I use it more for the diabetes, because that's sort of what I do. That's my interest, but you can use it as well for glaucoma as well. And with glaucoma, you look at the PHNR and you can see it down here. And this is a patient that if you look at it and you can see that everything's green in this patient. You know, this W wave is I always forget which way it is, but it's like one divided by the other. And you can see that everything's normal in this particular patient regarding glaucoma. But if we look at the next one, this is a patient who has some glaucomatous damage, and now especially in the right eye, whoops, sorry about that. And we can see here in the right eye, right, you can see all the red numbers in that right eye. And the left eye, you know, if you look down here, they're doing okay, but these are sort of getting scary, and you can see up here the waves and the implicit times are getting a little affected. So there's a patient that would have some glaucomatous damage in the right eye, more so than the left eye. So I just want to go over a couple quick cases so I can show you sort of how to use it in practice. So I think I've got a couple here. I have a glaucoma one. I might not do well, maybe we will, we'll see. But this is a patient, 46-year-old white female, type 2 diabetes for about 5 years, as well as hypertension. They're on metformin, and they're actually under A1C is 6.8, which is great. You really want your diabetic patients. We like to see their A1C less than 7 in a perfect world. So this patient's actually doing pretty well. When we look at the retinas actually look pretty good. There really doesn't appear to be, you know, any retinal damage there. And then when we do the DR assessment, we see the DR score is 12.5. So that's within normal limits. And we can see here that everything's, you know, green and looks quite nice. So this is a patient that we can just, you know, educate and follow, talk to them about good blood sugar control, and, you know, have them come back in a year, and we would repeat this in a year. And in theory, we repeat it. We look at the DR score, and let's say, you know, next year it's 22 or whatever, right? Then there's a patient's not doing well. If we check the patient in a year and it's still 12.5 or 12.7 or something like that, then this is a patient who's, you know, staying nice and stable. We don't need to be concerned. But if this number increases, it's a patient we're going to want to follow a little more closely, because we don't want anything bad to happen, right? Here's one here. This is a 53-year-old white male, type 1 diabetes for 20 years. Again, good hemoglobin A1C, good vision 20/20, and it's a patient with some known mild non-proliferative diabetic retinopathy. And we look here at the color photos, and there's just some small hemorrhages, and I highlighted them because it's hard to see sometimes, you know, when you present like this. But there's just some tiny little hemorrhages. But honestly, for a patient who's had type 1 diabetes for 20 years, you know, surprisingly, these are healthy appearing retinas. And then when we look at their OCTs are pretty uneventful as well. So we do the DR score on this patient, and you see it's 22.1. So that's getting close to our, you know, our magic number, 23.4. It's getting, you know, kind of close, right? So it says within normal limits, but when you look at right, the right eye, son of a God, every now and then I hit the wrong button here. When you look at the right eye, you can see all the green, and everything's green, right? The pupillary response is fine. And, you know, the amplitudes and the amplitudes rather, and the implicit times are fine. But when we look at the left eye, right, it's not quite as good. This is still green, but now we're starting to see the implicit time starting to get a little bit affected, as well as the pupillary response. So this is a patient, even though, right, they don't meet that 23.4, indicating 11 times more likely to need intervention within the next 3 years. This is an eye that I'm going to want to follow pretty closely. This left eye has more damage to it than it appears to have on clinical exam. So this is a patient that I'm going to want to follow more closely. Perhaps it's a patient that I would want to refer over to my retinal specialist. And a lot of times in patients like this, if they do a wide field fluorescein angiography, they might actually find some ischemia in their periphery that they didn't expect. So this is it really paints a little bit different picture in this patient. This is a glaucoma patient, and just real quickly, like I said, I don't use it as much for glaucoma. It's a good tool. It's just not my thing. I'm more of a retina guy, but this is a patient that's actually fairly stable, in the GCC over a period of time on both eyes, maybe a little bit more change in the left. And the visual field here is actually pretty good. And when we look at the PHNR, right, the right eye, the one that looked really, really stable, you can see everything looks very, very good. But the left eye that maybe showed a little change, we can actually see that there might be an issue going on. So this is a patient that might need a little more aggressive treatment in that left eye. So we can use our nerve fiber layer as well as a visual field, and this all together to really paint a nice clinical picture in my mind. And there's what the patient looks like. So, and this is a patient that is not doing well. And you can see here on the GCC, it's really increasing, as well as a nerve fiber layer is, I said increasing, but the red is increasing, meaning that you're getting more damage. Same thing with the nerve fiber layer. And you can see here from the rate change that they're really heading in the wrong direction, even perhaps a little more so in the left eye. And the visual field also shows damage. And you can see, whoops, that this patient, son of a biscuit. You can see here that this patient's having some issues. So anyway, I really like the Red Eval. I like the full field ERG. I think it's a great tool in a medical optometry type practice, right? It gives you an objective measurement of their level of diabetic retinopathy, right? So you're going to look at the eye, you're going to grade the diabetic retinopathy, mild, moderate, what have you, based on the level of retinopathy. But we know from studies that even retinal specialists have some disagreements about how to classify patients. So nice thing about this is it gives you just one number. It's an objective measurement of diabetic retinopathy, right? And retinal health. And you can use that number, like I said, to follow the patient over time and make sure they're not doing worse. And then it will help you hopefully refer these patients out in a timely fashion that might need treatment. It can detect cellular stress not observed on conventional OCT or retinal photos, because we know that functional loss often precedes structural loss, just like in glaucoma. Helps make clinical decisions when conventional structure function info conflicts. Better referrals and treatment, both structure and function tests are used. And I really firmly believe that when you use structure and function together, you get a better clinical picture of the health of the eye, and then it helps you decide what you want to do and how you want to take care of those patients. I just want to, let's see, just checking the time here. Yeah, we're doing fine. So I want to shift gears a little bit. And that was sort of the functional aspect of the eye. And I want to talk a little bit about the structural tests. I want to talk a little bit about OCT, angiography, and for our remaining 20 so minutes or whatever we have. But I have OCT angiography. I really like it. I find it very, very useful in patients. It helps image the retinal microvascular without dye injection. So previously, if we wanted to know if a patient had ischemia or neovascularization or something like that, or if they had leakage from diabetic retinopathy, from age-related macular degeneration, we would have to do a traditional fluorescein where we inject the dye into the patient and all of that. And excuse me. That's evasive, right? And most of us as optometrists, depending on the state we live in, most optometrists can't do fluoresceins because it is an invasive test. But now with OCT angiography, we have a way to image a retinal microvascular without dye injection. So that's actually, it's pretty cool. The other thing I like about it displays structure and function on a single imaging system. Previously I had my OCT machine, I had my camera doing the FA, and you kind of look back and forth. Okay, this area corresponds with this area, and that sort of thing. But now, it's all on one screen, so you really, it gives you a better clinical picture. You know exactly what you're talking about and exactly what area you're focused in on. Essentially, the way that it works is, these new OCTs, they scan so quickly. The first generation of OCTs that came out scanned about 26,000 scans per second. These newer units go up to 80,000, and some of the newer ones even more, 100,000 or so scans per second. And essentially what happens is, since it scans so quickly, it can scan over a blood vessel, and it can see if there's any change in that blood vessel over a given period of time. And if there's no change in that blood vessel as it scans 80,000 times a second, that means that it's not a working blood vessel. There's no blood running through that blood vessel. If they find that there is blood running through that blood vessel, right, there is a change, then that's an open patent blood vessel. So it uses this fast scanning to detect flow, and then it uses that flow to extrapolate whether or not there's leakage or blood or that sort of thing. So that's essentially how it works. And it's great because you can see retinal vasculature without referring patients out of the practice, visualize signs of disease earlier, make more intelligent referrals, right? Which really it's all about, and manage more pathology, keep patients in the practice longer, and elevate the practice with state-of-the-art imaging technology, right? And I'll be honest with you, when I do this on patients, I explain to them what we're doing. They don't always get it, right? But they're like, oh, that's pretty cool. And it's always nice when you have sort of that wow factor in your practice, whatever that piece of equipment is, right? Whether it's a Red Eval or an OCT, whatever it is, the patient's like, oh yeah, that's pretty cool. I mean, it just lets them know that you're, up on things, that you have state-of-the-art equipment, and you're really staying up on things, and it makes them feel good to know that they're being taken care of with the latest, best equipment. And the thing I use it for most, to be honest with you, is looking for patients that convert from dry to wet AMD. I have a large AMD practice within my practice at the VA. I have a lot of AMD patients. We have a retinal specialist that we work closely with for injections and what have you. So that's probably what I use it for the most, is trying to find those patients that are going to convert from dry to wet macular degeneration. I also use it a little bit for monitoring diabetic patients, but not as much, to be honest. And there's other things there as well. But we kind of talked about this. We don't need to talk, and we can skip through a couple of these. So just like any piece of equipment you get, when you get it, it always takes you a little bit to figure out what you're doing with that piece of equipment. And when I first got this, I think the biggest change is that when we think about OCTs, we generally think about cross sections, right? But really, when you're doing an OCT angiography, you're looking at the en face images. And these are the images that, you look straight down into the eye, rather than the cross sections that we become familiar with the OCT. So these are really so it's a little different way to use the OCT, and you have to look at it slightly different. And it takes a couple patients or what have you to figure out what you're looking at and what you're seeing, like any piece of new equipment. But I always tell people, if I can figure it out, anyone can figure it out, quite frankly. But it looks at a couple different layers of the eye. You can see here, it looks at the superficial blood vessels, and then the deep capillary plexus right below it. And then this looks at the photoreceptor layer here. And then we looked at the choroid. So it looks at 4 different layers, right? The superficial capillary plexus and the deep capillary plexus. And superficial, we see large blood vessels. And then underneath that, we see the capillaries here. And then the deep capillary plexus, what happens, you're right underneath these vessels here. So all you have is a deep capillary plexus is what we're looking at. The outer retinal zone, that's where the photoreceptors are. Whoops. The photoreceptors are and stuff. That's avascular. So if you see anything in this area, that's generally a bad thing, quite frankly. You really should not see any blood vessels in there. And the choroid is very vascularized, and it kind of looks like a sponge, but you shouldn't see individual blood vessels in there. So when we think about diabetes, right, we're going to see capillary dropout in these top 2 layers, because that's where you see the damage from the diabetes. If we're looking for a patient with AMD, we're going to see the changes in the outer retina zone and the choroid. choroid. So what you'll see is a blood vessel in the choroid, and then if it pops through Brooks into the eye, then you'll see something in the outer retinal zone, which is supposed to be avascular. So you always have to know what normal looks like, so you know what abnormal looks like, right? So this is an example of a patient with a diabetic retinopathy, and you can see here these darker areas here, and this kind of retooling and remodeling of the blood vessels is what we start to see in early retinopathy, these little dark areas of ischemia. And also you can start to see this fovea is actually enlarging. So you get an enlargement of the foveal avascular zone as you get ischemia. So you see that more in the superficial, a little bit in the deep as well, but the outer retina and the choroid are unaffected in diabetes. Here's an example of a patient with a choroidal neovascular membrane. And again, superficial and deep are fine, no problem there. But when we get into the choroid or the outer retina is where we start to see our damage, and you can see them right there. All right, and here we'll go through in the interest of time. Branch retinal vein occlusion is just kind of looks cool, right? You see a lot of ischemia in these patients. It's a choroidal neovascular membrane. So let me just show you a case here of a patient of mine, and this was actually one of the first patients that I did an OCT angiography on. And I remember distinctly because the company came in and they set me up, and I wanted to see how the OCT angiography, how it relates to the fluorescein, because fluorescein was our standard for macular degeneration as well as diabetic retinopathy. So I wanted to see how it sort of went hand in hand, and was this going to be helpful for our clinical practice, right? So this patient had dry AMD for years. His vision slightly reduced about 20/40 to 20/30. He didn't do home AMs or grid because, let's be honest, most patients don't do home AMs or grids. I've been practicing for a long time, and I can't remember the last time a patient said, "Oh, Dr. Ferrucci, I'm coming in because I have a change on the AMs or grid." It just really doesn't really happen like that. He's also diabetic, but has not had any retinopathy. When he came in, his left eye, there was a change in the vision. It was actually 20/70 in that eye, and he really didn't notice that change until my tech checked his vision. And here's what he looks like on clinical exam. And this pigment has just been there forever. It's probably nothing, to be honest. But you see he's 20/40 in the right eye, and you can, I think, appreciate some drusen here. He's 20/70 in the left eye, and it certainly looks like he has a little hemorrhage here in his macula area, right? So there it is right there. It looks like a little hemorrhage. And on clinical exam, it was obvious he did have a hemorrhage, and it certainly looked like there was some swelling there, some elevation. So I'm going to do the OCT. Here's his right eye, and you can see in his right eye, everything looks pretty good here on the map. And you can just see he's got some drusen here, but overall everything looks okay. But when we do the left eye, which is the eye we're concerned about, we can see that he has an issue, right? You can see here he's got the loss of his foveal pit. He's got some intraretinal fluid here, and you can see here as well on the Retina Map that he's got some elevation right underneath his macula. Right, and there it is on the raster, and you always want to sort of look and make sure you're not missing anything. But you're going to see it again. He's got some intraretinal edema, and things are not looking so fantastic. This is the Retina Map. It's nice to follow patients over time, but this is what I wanted to show you. Here's the OCT angiography, and remember I told you that the outer retina is supposed to be optically clear, but here we have it's a little tuft of blood vessels indicating an early choroidal neovascular membrane, and here it is in the choroid as well. So we have a choroidal neovascular membrane that's popped through the choroid into the outer retina. So this patient has a choroidal neovascular membrane. He's converted from dry to wet macular degeneration, and we're going to need to get him some treatment. There it is again. Right, here's his other eye. I did the OCTA on his other eye just because I'm doing it on one eye. I'm going to do it on the other eye. Didn't suspect anything here. And you can see the outer retina is fine. It's optically clear, nothing going on. And the choroid, there's a couple little, sometimes you get these little blood vessels. So it's probably an artifact, but there's nothing growing there. So he's dry on the right. and he's wet on the left. I did a fluorescein because at this point we're still doing fluoresceins, and it really correlates nicely. You can see here on the fluorescein, he's got an area leaking and getting worse with time. So this is a patient stage 2 CNVM. We're going to send him over to the retinal specialist for Avastin, and the patient comes back to see me after the 3 Avastin, and we repeat the OCT angiography on him. And here you can see that he just has this little tough left, right? It used to look like a little smiley face. Now it sort of looks like a snail or something, but it's just got one little area left. It's much improved. And you can see down here that all that intraretinal edema actually went away. So the patient's doing better. We send him back. He gets a couple more injections, and he actually did quite well at the end of the day. Right, so there it is, a little bit of the there. Here's another patient, right, who comes in, 83-year-old male. We've been following him for quite some time for dry macular degeneration. He feels that his vision has gotten a little bit worse in the left eye, and he doesn't do the home AMSA grid, but my resident is nice enough to do the AMSA grid in office, and he does have an area of metamorphopsia. And when he sort of asked about it, he says, oh yeah, I've kind of noticed that a little bit for the last couple of months. Here's his clinical picture. You can see he's 20/30 both eyes, and he's got some pretty big soft confluent drusen, probably more on the right than the left, although the left is the one that he feels is changing a little bit. Do the OCT, right? And it really looks pretty good. We've got some big drusen. You can see some big drusen here, right? But there doesn't appear to be any fluid. Whenever I see big drusen like this, I always want to look adjacent to it to make sure there's no fluid, and it actually looks pretty good. And here's the other eye, and again, it looks nice. There's just some drusen here, but there's no fluid or elevation or anything like that. And the raster, we look all through the posterior pole, and we find that fine as well. I'm going to do an OCTA angiography. I have it. Why not? Outer retina and the choroid look fine. This is probably just a little bit of an artifact from this one big drusen casting a shadow, but the outer retina and choroid look fine on the left eye. And here it is again. I had the right eye, but I somehow misplaced it, but that was fine as well. So this is a patient that we don't need to send out. He just has dry macular degeneration. He's got a multiple confluent drusen, no fluid on the OCT. So this is a patient that we can continue to follow, make sure he's taking his vitamins, and have him come back in a couple months perhaps to repeat the OCT so we can see what's going on with this patient. Diabetes, let me see how we're doing time here. Diabetes, this is a diabetic patient who, we saw this patient in the 20/20 vision, but right here where these exudates are, it looked like they might have a little bit of thickening. So we did the OCT, and sure enough, you can see that there certainly is a little area of thickening right here, off of his macula. So back when we were in school, they hammered us with these definitions of clinically significant macular edema, right? The thickening was within 1 disc diameter, greater than 1 disc diameter, and these types of definitions. But now with the OCT, there's really 2 kinds of diabetic macular edema: center involved and non-center involved. This would be non-center involved because this center ring right here is not involved. So this is non-center involved diabetic macular edema in his right eye. Left eye looks fine, right? And here you can see this is where the little pocket of fluid is. So this is a patient that either you're going to send over to your retinal specialist if you want to, but a lot of these patients won't get treatment until it gets closer to the macula. So this is something you could follow if you wanted to do that. And here's another patient. Oh, I thought I had the center involved one. I guess I don't. This is a patient that had decreased vision, and I thought that he was going to have diabetic macular edema because he had diabetes. He had about moderate non-proliferative diabetic retinopathy. I thought he was going to have some edema. But when I did the OCT, visual field, right? When I did the OCT, I was surprised to see that he really didn't have any edema. But what this patient has, and I'll show you here in a second, right? What he has is macular ischemia. His fovea in his right eye, that's about 20/50, is starting to have a lot of ischemia. And you can see that his fovea is really quite enlarged here. And you can see all these areas of ischemia around it, right? So there it is again. And if we compare the right to the left, you can see how much bigger the fovea is on the right eye than the left eye. So this is a patient that has macular ischemia, and he has his vision loss not from edema, but from macular ischemia. So the good news, if there is any good news, is that this patient that doesn't need treatment, doesn't need any more injections, because injections aren't going to help his ischemia. But the bad news is that, unfortunately, we don't have any way that we can restore vision at this point once patients have loss from ischemia. So all we can do is optimize his blood pressure and blood sugar and keep an eye on the patient. But in the previous, before we got OCT angiography, if we wanted to see if a patient had ischemia, we would have to do a traditional fluorescein. And it was very, very hard to tell from a traditional fluorescein whether or not there was any ischemia. It's much easier to look at the foveal avascular zone when we do OCT angiography. And we can use that and find, there's new software now where you can actually measure the foveal avascular zone in these diabetic patients and follow it over time. And if you see an enlargement in their foveal avascular zone, this is a patient that's getting a lot of ischemia and is probably not doing as well as you think, perhaps based on their retinal health. So it's just another way to follow our patients with diabetes more closely. And you can also, it also has some nice applications in glaucoma as well. I don't use it as much for that. I use it more in my diabetic patients and certainly my AMD patients. I mean, at this point, we rarely do a fluorescein angiography for our AMD patients, and we really rely on the OCT angiography. For our diabetic patients, we're still doing fluoresceins. We usually do wide field fluoresceins to really get a good picture of their total retinal health. So we do that, but we're using the OCTs a lot for that. So that's what I wanted to talk to you about today. I really think, the Red Eval, it's a nice tool to really, give you an objective measurement of the retinal health, particularly in patients with diabetes, by using that diabetic retinal assessment tool that I think is a real powerful tool. You can use that to educate your patients. You can use that to follow their health over time, and then hopefully to make more intelligent referrals over to the retinal specialist when you see the patient heading in the wrong direction. And then the OCT and OCT angiography, great way to measure the structural health of the eye. And by using different tools, structure and function together, I think we get a better picture of what's going on with a patient and whether or not they have any meaningful disease that needs to be treated. So with that, I'll open it up to a couple questions if
Doctor,
there are any.
So thank you so much for taking your time out of your day. I wanted to direct your attention over down to the question and answer section on the bottom of your screen. You'll see some of the questions pop up.
Yep. Okay. You want me to just?
Yeah, and you can read them off. I marked them for you. Whatever you'd like to read off, we'll take a few questions. We can start with the first one. How does retinal disease other than diabetes and glaucoma, such as previous BRVO or surgeries, PRP, focal laser, affect the results and cutoff of the number of the 23.4 for the Red Eval?
Yeah, that is a good question. And if a patient has the glaucoma, not so much, but if they have other damage from another type of disease, it can change that, a little bit. And same thing, when you're looking at the eye, same thing, right? If you're looking at an eye, it's is it damage from the vein occlusion or is it from the diabetes? But nonetheless, it still gives you useful information that you can, assess the overall health of the eye. And you can do the Red Eval for, I talked about it in diabetes, and that's what I mainly use it for. But there's a bunch of different types of programs on it, and you can run a bunch of different tests. So, I did one as an example, a patient with retinitis pigmentosa. So you want to see, do they have any damage from the retinitis pigmentosa? So there's different programs you can run on it as well. So it really can be useful in a myriad of disease. I saw someone mention plaquenil testing, and I haven't used it for that, but I'm pretty sure that there is it would have some clinical utility in that as well.
Got it. And then for suspicious individuals who don't show any retinopathy, how often is the Red Eval repeated or used?
Yeah. So, I think it depends on their level of retinopathy, right? And I use the two together. So if the number's bad or getting bad and they have some retinopathy, maybe I'm going to see that patient 3, 4, 6 months, whatever. If there's no retinopathy and the number is good, that's a patient I'll probably see back, in a year and repeat the Red Eval in a year. I've not had it yet for a year, so I haven't done that the second time, but that's what my plan is, So I would say it depends on that particular patient, what their level of retinopathy is, as well as their DR score, and use those two together to figure out when you want to do it, when you want to see the patient next.
Okay, and are you referring patients for fluorescein angiography in the periphery for treatment based on the abnormal ERG findings?
Yeah,
and then
so right.
Specialists incorporating this into their treatment plan.
Yeah, so and how retinal specialists are using it. I mean, I'm not going to speak for retinal specialists, but yeah, if I see a patient with that number is getting 23.4 or more, to me that's a patient that probably has a occult disease that we're not seeing. So in that case, I probably would refer that over to our retinal specialist and, excuse me, have them get a wide field fluorescein. And I would be very surprised if they didn't show some sort of ischemia in the retina that just wasn't clear on their clinical exam.
Okay, got it. And if the DR score is above 23.4, how repeatable is that score? If you do a test back to back, are they the same? And
Yeah,
do you repeat the test in about a week or so, in a month or so for repeatability purposes?
Yeah, so it's very repeatable. So if it's 23.4, or more, I'm usually pretty comfortable that that's what it is, and I don't think there'd be any harm if you wanted to have the patient come back and do it, treat them, check it again. I don't think there's any harm in that. I generally don't do that just because, I mean, to be honest with you, I don't know if any of you, when you were students or anyone here works at a VA or as a student, we get pretty busy, so I don't always have time to see these patients, but you certainly could do that, but it is very repeatable. So I don't think you need to do that.
Okay, thank you. And does it do for the ERG? We'll probably ask this for Ian later. What's the, there's a question for do you typically do a 3-month ARMD follow-up and why not 4 to 6 months?
So for AMD, it really, depends on their level of AMD, their acuity, how it looks on OCT. There's a lot of factors for AMD that go into when I'm going to see the patient back. And it can be, as soon as 3 months, it could be as much as, 12 months, depending on a bunch of factors. So it just really depends on the individual patient. I don't have to me, AMD is not quite as cookbook as, if you have a patient with moderate NPDR, we see a patient back in 6 months. If it's, whatever, if it's mild, we'll see him back in a year. I think with AMD, you have to use more information to really figure out when you want to see the patient back.
Okay. And then how is FFERG different from MFERG?
That's probably above my price point. How's that? I don't really, like I said, I know how to use it in my clinic. I don't 100% understand the difference. Maybe Ian does. I'm not really sure. But the full field it looks at the full field, whereas I believe that the multifocal does not look at the full field, but I'm not 100% sure.
Okay. Thank you.
Sure.
And another question on the OCTA, does the FAZ zone change always correlate with the VA change? How often do you do OCTA?
So usually if you start to get macular ischemia, you usually will start to get a change in the vision. So once you start to see that, you are going to get some vision loss. So once you get ischemia, you almost always have vision loss. And I don't know how. I would probably see that patient back in 3 months. I would probably also, and again, in my mind, if they have macular ischemia, they'll probably also have peripheral ischemia as well. So I would again send that patient out to have a full field, a wide field rather, fluorescein angiography. But I would probably follow the patient, every 3 months, because something I think bad is going to happen to that patient soon.
Okay. And then I think we have just 2 more questions. I have an OCTA already. If I did an OCT, can I go back and look at the OCTA historically, or does it need to be done as an OCTA when the patient is being tested?
Yeah, it's a different test. So no, you can't go back. Like, if you didn't do it, you didn't do it. So you can't go back and do it. So yeah, you have to do it at that time.
Okay, got it. And then last question, what machine are you using for your OCTA?
Oh, so I have the OptiView is the one that I have, which that's what I've had for a while. So I have the OptiView. It's called the Avante, I believe it's called. And now they've renamed their company, Visionix or Visionix or Visionix. I don't even know what they call it. But I have the OptiView. OptiView makes one, Zeiss makes one, Heidelberg makes one. My understanding, Topcon has a OCTA unit approved in Europe, but it's not yet approved in the United States. It was supposed to be, but with COVID, things got a little messed up. So I think those are the 3 brands that I'm familiar with, and they're all good. I mean, they do things slightly differently. They might look at slightly different levels of the retina, but they're all essentially the same. But I have the OptiView.
Okay, well, thank you so much.
You are most welcome.
Yeah, thank you. So we want to thank you, Dr. Ferrucci, for taking this early Sunday with us. I know your time is very valuable. You actually have 3 minutes to hop across the street to your next lecture. So big thanks from us, and we really I hope you enjoy the rest of your Sunday.
Well, thank you so much. Nice talking to everyone, and I appreciate your attention. You take care.
And before you go, can you unshare your screen so we can go ahead and thank you.
You got it.
All right, thank you, and have a good rest of your day. Take care.
Take care.
All right, everyone, thank you so much for staying for this amazing lecture. And I want to now take this time to thank and introduce our sponsor, Ian McMillan from Konan Medical, for making this CE possible. Now, Ian will take a few minutes to go ahead and share with everyone this exciting and new technology that Dr. Ferrucci was talking about, the Red Eval. It'll help you take better care of your patients, as he mentioned, and also bring in extra revenue for your practice as well. There's going to be a quick question answering session with Ian. So any questions you have, go ahead and type it on the question and answering section. I'll go ahead and review that with Ian. And after his talk, we will raffle off the $100 cash prize winner. So make sure to stay to the very end. I think Ian's hopping on right now.
I'm here. Would you like me to share my screen? Good morning, everyone.
Go ahead. Yes, go ahead, Ian. Go ahead and share your screen.
All right. Good morning, everybody. Thanks for being here. I always enjoy listening to Dr. Ferrucci. I think he's a great clinician. I'm the head of sales and marketing for Konan Medical. We're in Irvine, California, and we're going to talk a little bit, very briefly, about kind of where this fits, what the financials look like, and then I've got a really good deal for you guys to review if anybody is interested or thinking about adopting this technology. So ERGs are historically a little bit complicated, and one of the problems with any visual electrophysiology is repeatability, and this feature is built into this product that address all of that. So this is our #1 selling product. The adoption is really fast, and what I mean by that is this product gets used, it gets implemented quickly. It is not sitting in a cupboard somewhere collecting dust. You saw some of the reports. The printouts are very easy. The photopic negative response, looking at optic nerve atrophy, is probably the most complicated one, but we've got clinical application specialists that can help review actual cases with you once you've started to collect some data. I encourage anybody that's looking at the technology or thinking about taking a hard look at it to go to learn.konanmedical.com, and because we do online training, 99% of this product, 99% of the customers, they get going on their own by taking an online course. And then we support that with one-on-one clinical support. But you can sign up for a course for free at any time, and it'll give you a good idea of exactly what's involved. Also, if you go to the website, I've got the URL in another slide. If you go to the website, there's a video, a start to finish video of exactly how to do this. And you can see it's really simple. It's easy on the techs, easy on the patients. And we see what the implementation and utilization looks like, because at some point you've got to buy another box of electrodes, right? And we see when that happens, and I'll talk about that in a little bit. Also, I did make some notes, so I'm going to hit some of the outstanding questions that came through at the end as well. But let's look at financials. So list price is just under $19,000. Cost of electrodes is $14 per patient or per test. CPT code is 92273. Medicare national average is about 125. It's as high as 140 in some regions. I would know if there were issues with doctors getting paid. I'd be the first one to hear about it. And we've been selling the product for 3 years, and I'm not hearing any issues at all with customers getting paid. And this is probably the best testimonial of all, is the multiple repeat customers. So I've got a private practice. This is not private equity. I've got a private practice group. One example here in California. They have 12 locations. They started off with one device, and this is back when they had 8 locations. They bought one, and they said, well, if it works out well, we'll probably implement across the other 7 locations over the next year. Well, they bought one. 2 weeks later, they put an order in for 7. When they have opened those additional 4 practices, there has been a Red Eval in the practice on opening day. So they're now up to 12. I've got a customer that operates a fairly large nursing home operation. He started with 1. I think he's up to 15 now. Nobody buys a device and then buys 11 more unless it's going really well for them. So let's talk about ROI a little bit. So let's just assume you finance it. You're looking at about $550 a month over 36 months. Your break even is only 5 tests a month. And that, when I mean break even, that is paying for the electrode and making your payment. You need 5 tests a month to pay for that. So I'm subtracting $14 from whatever you get paid in reimbursement. And so a low volume user, let's say 20 a month, that's 1 a day. Your net profit on that is $1,700 a month, or 20 grand a year. And I would say that the range is probably, I would say the average range is 20 to 40 a month. So that would be maybe 1 box of sensor strips. There's 50 tests or 50 pairs in a box. So doctors are ordering maybe 1 box every 2 months or 1 a month. That would not be uncommon. So that's 40 grand a year. Now, if you're buying it with cash or check or credit card, you break even. You're going to pay this off in 6 to 8 months with reasonable utilization. So we do a lot of work in terms of leasing. The rate I quoted was, or the payment I quoted was based on 4.89%. That's with U.S. Bank medical equipment leasing. You can pick the term from 24 to 60 months. So we accept checks and credit cards as well if you want to earn some points. And if you have a preferred equipment leasing vendor, as many of you probably do, we work with most of them. So you're certainly not compelled to use U.S. Bank. They do a good job though. Okay, here's the deal. So firstly, I'm guaranteeing this is going to be the best offer this year, and actually this is the best offer we have ever put out there. So please don't share this outside the group. it is confidential and it is for you guys only. I can promise you, nobody's getting anything close to this at Vision Expo West or anywhere else. Most of the Red Evals are sold at full list. You know, it's well priced. It's not terribly expensive. The first line, $500 off. That's about what our show special is, without anything else. So for you guys, we're going to add an extra box of sensor strips at zero cost. So you're going to get 2 boxes. So that's enough to do 100 exams. Okay, so that's worth $700. You're also going to get an extra year of a premium warranty. So that's $1,500. So the total package for ODsonFinance is valued at $2,700. And if we get 10 or more units sold through this program, we'll send everybody an extra box of electrodes for $1. Now, why $1? I have to put that in there because we live in California, and if I give anybody anything for free, the government of California wants us to pay full sales tax on the full retail value. It makes no sense. It's a bit of a silly regulation, but anyway, that's why I have to charge you $1 if I send you a box after you get your original package. So this is good till May 15th. So anybody who wants to take advantage of this needs to have the deal consummated by then. And your group has already started ordering. All right, so we've already closed a couple. So I'm going to go through the couple of questions I have noted here, and then Julie, I'll let you fire away once we're done. Once I'm done here. So the first question I'm going to address is screening versus billing on the diabetic retinopathy and assessment. So you could use this as a screening tool, absolutely. And as a matter of fact, this protocol has been used in Europe on a device that's branded under Welsh Allen, and all it has on it is the diabetic retinopathy assessment, and it's used strictly as a screening tool. However, it is billed the same under 92273, CPT code 92273, as any other ERG. So from a billing and coding perspective, it's no different than running a flicker or photopic negative response or a flash. So really, it's how you want to use it. So you could order that test, or you could use it on every one of your patients with diabetes. If you want to screen them, that's up to you. Next question is, can you bill the same day as OCT? And the answer is yes. There's no restrictions at all. As a matter of fact, there's nothing that says anything about in any of the national or local coverage determinations. There's nothing that restricts how many times you use this device. Next question was about, how or when, how much or when to repeat. It is absolutely appropriate. As a matter of fact, it's in the guidelines for global ERG standards to, if you're making if this is factoring into medical decision making, so typically you've got an abnormal response if you're doing that, right? It is absolutely appropriate to bring the patient back in and see if it's repeatable. That validates that everything was done correctly the first time. The device is highly repeatable, but if the technician didn't do a very good job of securing electrodes, that could end up in a poor result, and maybe the electrodes are better applied in the second test. That could be a reason why things would change because of how the test was administered. But there's no problem at all with repeating this to make sure that what you're seeing is repeatable and valid. And if you're going to make a decision on it, that would be prudent. In terms of follow-up, that's really up to you. Medically necessary, whether it's 6 months, 8 months, 12 months, that's your decision. The next question was on full field ERG versus multifocal ERG, and that kind of segues into Plaquenil. Full field ERG is just that. It's a full field, so it's 120 degrees. So it's the consolidated or amalgamated responses of the photoreceptors in the retina. Multifocal is very much macula, and it uses a pattern. And the pattern could get more and more detailed. It's not done very often. It's not a common modality. It's a good multifocal system. So Red Eval does not do multifocal. It's a good multifocal system. Includes some pupillary tracking, because if the eyes are moving around all over the place, the multifocal just doesn't work. So it's very different. Full field ERG is not supported for plaquenil. This plaquenil, creates this bullseye in the macula. It's called a bullseye. It shows up beautifully on an MF ERG. If you look at the American Academy of Ophthalmology guidelines, multifocal ERG is the only modality of ERG that is supported for ancillary testing outside of OCT and fields. And then the last question I have is, does this do VEP or EOG? It does not do EOG. It does do VEP. There's a little kit that you get. It's $175. Adds some different wiring, and gives you a little gold cup, reusable scalp electrode. But I want to point out that flash VEP is really just a gross measurement of whether the nerve's intact. Is the signal getting from the retina to the primary visual cortex? Yes or no? That's it. So it's not like pattern VEP. So that's all the questions I have that I made notes of during the presentation, and I'm happy to answer any others.
All right, Ian, I think we got a lot of repeating questions. If the patient does not have diabetic retinopathy, but they do indeed have diabetes, and the ERG, can we bill for the ERG?
So this is a good question. It's unfortunate. What I'm told, or what I've learned, is that billing for patients with diabetes is a little bit different than, let's say, billing for a patient that has a family history of glaucoma. So, my A1C is high, is not a reason to run a bunch of diagnostics. So there needs to be something, and normally this comes out in your discussion with the patient, or do they feel like they're seeing as well as they used to? Is there a little bit of refractive error? Is vision blurry? If everything else looks pretty good, then there needs to be something, to start. It's unfortunate that that's the way it is, because essentially, they're saying, well, we want something showing up on the fundus image before you can be, gloves off and run diagnostics, which to me doesn't make any sense, but it is what it is. But most patients will have, certainly something to go on, to open up that opportunity to take a hard look with some good diagnostics.
Awesome. I know that there's a lot of doctors that also manage glaucoma suspects. They may not see a lot of patients who have active diabetic retinopathy. So is this something that doctors can bill for patients who are suspects for glaucoma, or who already are having glaucoma?
Yeah, so the short answer is that you cannot bill an ERG under any of the glaucoma codes, but all of the optic atrophy codes are fine. So I think glaucoma is all the H40 codes, and optic atrophy is the H47 range. So H47 is fine. Most private payers are going to kick back an ERG if you use H40. So the way I explain this, and have been for since some of the the coding changed, I think going back to 2019, 2018. Essentially, you can use it to follow optic atrophy, but once you're calling it glaucoma, they don't want you using it to be following somebody who is diagnosed and under treatment to see how the treatment's doing. So you know, you could be following a patient for quite some time before that complete diagnosis happens, and then technically you should switch to the H40 code, and that will probably get kicked back by most private payers and Medicare.
Okay, got it. And then how does the ERG correlate to macular degeneration levels and retinal function?
Yeah, if I could just back up and just say one thing about glaucoma.
Okay.
Most of our customers are using it in the way I described. In other words, I would say that the majority of this device's utilization is in glaucoma. I don't want to say a percentage, but many doctors are using it for glaucoma and diabetes.
And they're using it as the glaucoma optic atrophy code for billing, correct?
All the optic atrophy codes.
Yeah.
Yeah.
Okay.
So AMD. So if you think about AMD is a macular disease, obviously by definition, and this is a full field ERG, which means we're going out to 60 degrees in each eye. So that begs the question, right? If we're seeing AMD and there's visible damage, it's possible to get a decent ERG because of the contributions from the photoreceptors outside the damaged area. So you certainly can use it, but it's not going to be as definitive as something like diabetic retinopathy, which affects the whole retina or can affect the whole retina.
Okay, good. Anybody else has any other questions that I can ask Ian before we close the lecture today? Any closing points, Ian, that you have?
No, just check out the website. There's good information there. There's a whole section on Red Eval. There is a video that shows the test being done in real time, start to finish, with somebody who's just doing absolutely normally. So when you watch that video, it's just under 5 minutes, shows how to clean the skin properly, shows how to apply the electrodes, running the test, and then removing the electrodes. That whole process is under 5 minutes. And again, that video was shot in real time. We weren't trying to hurry or make it look faster than it really is.
Okay.
You can take the online course to check out what learning is like to get this thing implemented. There's my email address for questions. And then during business hours, you can chat with us on the website, and that's the main phone number.
And then Ian, just 3 more questions for you.
Sure.
Anyone that's, you guys are free to enjoy your Sunday. I just want to answer some of the questions that some of the doctors have that we've missed. Will all of this billing create a red flag for medical audit due to a low incidence of use across all of medicine?
No, because the utilization of the product is not that low. I mean, there isn't 10,000 of these in the market, but there's many hundreds. And if you just use it when medically necessary, and I would suggest that there's a pretty close correlation to which is what Dr. Ferrucci went through, which is how many OCTs are you doing, and I don't know a firm percentage, but I would say that if you're ordering an OCT 50 to 75% of the time, you might want to consider ordering an ERG as well, or maybe more. But this is not new in terms of it being utilized. Again, I'm not hearing of any issues. But, you know, obviously, you know, good documentation as always, right?
Yep, that's correct. And then last question, how long does the test take to run? Does it need to be run in the dark? And can you run it on pediatric patients who you are suspicious of having amblyopia?
Yeah, so this is used a lot in pediatrics, and there is a new pediatric census strip coming out, along with some normative data. Basically, it's a smaller census strip, but it's being used currently with the current census strips extensively in pediatrics. It's very tolerable. It does not have to be in a dark room. You can see it in the picture there. It's got this soft rubber eye cup. We do repeatable, reliable ERGs on trade show floors under the bright lights all the time. That's not the ideal environment, but you can literally do this anywhere, in a hotel lobby, on a plane, anywhere. What the device will do, it's got all kinds of really cool feedback mechanisms. So as an example, if the cup is not properly placed around the eye, in other words, if it's not blocking light, if there's a bright light seeping in from the side, there's a light meter inside the device, and it'll tell you. It'll tell you whether you've acquired the pupil or not. You just got to get it in this big green circle. It'll tell you if you lose acquisition of the pupil. There's a video screen so you can see exactly what you're doing. So if the electrode is loose on the skin, or the wire's not connected properly, it'll tell you. So if you complete, you know, what is typically a 5-minute procedure, you know, cleaning the skin, putting the electrodes on, running the test, and then removing the electrodes, you can run a couple of protocols at the same time inside that. You know, let's say you do 3 protocols in a row. Now you may be up to 6 minutes. When you complete all of that, you've got good data, because it'll tell you if anything's going wrong during the procedure.
All right, Ian, thank you so much. I know that we took a lot of your time this morning. I wanted to also give a shout out to our raffle winner. It is Dr. Actually, there you go. Henry Patterson. I think you just commented too. So thank you so much, Henry, for tuning in, staying this Sunday morning and listening to Ian and Dr. Ferrucci. Please give us an email at admins@ODsonFinance.com to claim your prize. Everyone else, if you have any questions, email myself at admins@ODsonFinance.com for the ICD-10 codes, as well for, well, go ahead and ask Dr. Ferrucci for his slides as well. And we will end the event now, and hopefully everyone has a great rest of your Sunday. Thank you.
Thanks, everyone. Thanks for being here.
Thank you so much, Ian.
Bye now.
Bye-bye.